Hi, my name is Dr. Salil Kandwala, and I am the Director of Advanced Urogynecology of Michigan. So let us now talk about what is fecal incontinence, or what we now call accidental bowel leakage. So as you can see in the slide, accidental bowel leakage is involuntary passage of stool beyond one's control, and in some cases, involuntary passage of gas beyond one's control. So this is very common. 25% of people over the age of 65 are affected by this. And when you talk about patients who are in a nursing home, almost 50% of people in a nursing home have bowel leakage problems. And as it's obvious, it's a very embarrassing and a debilitating problem. And also it affects the local hygiene because it causes constant irritation from the soiling of the stools. There's a perpetual odor, and therefore patients get isolated. They don't want to mix or talk to anybody because they constantly feel that they have loss of control, they may be smelling, or sometimes just walking and losing gas control could be very embarrassing to most people. It occurs more frequently, like 8 times more frequently in women than in men. So there are many causes of this. Childbirth obviously is the number one cause, especially if there's a large baby that came through or it's a forceps delivery. Rectal surgery such as hemorrhoid surgery could also compromise the sphincter muscle. Neurological problems such as multiple sclerosis, and even constipation. Remember, constipation you may think is the paradox, right? How can someone who's constipated also have leakage? Well, because when someone is constipated, it puts a lot of pressure on the sphincter muscle from the impacted stools, and that causes seepage of stools and also gas leakage. Part of the gas leakage that happens in patients with constipation is because of excessive production of gas, as the stools are just staying there and the bacteria keep working on the stools and produce more gas. And also in some chronic conditions such as ulcerative colitis or Crohn's disease. So let's look at the anatomy of this rectal sphincter or the anal sphincter. So here you have the bowel, which is coming down, and at the end you have what is known as the anal canal, the last part of the bowel. Now what is interesting in the bowel is that the entire bowel is basically churning downwards. So everything is moving downwards and it is contracting downwards. So this entire bowel is moving down, 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 but for this lower part, which is this area right here, which opposes it. So this is trying to hold the stools in. Otherwise, what will be happening is if it keeps contracting downwards, we'll be losing bowel control all the time. But that doesn't really happen because this sphincter muscle right here holds it in and contracts it down so that there is no loss of stools. And that's in the form of two sphincters, the inside sphincter and the outside sphincter. So we call accidental bowel leakage as essentially different types. A common is passive incontinence, where there is loss without knowing that it happened. It just comes out and the patient realizes that when she sees her underwear or a pad, there is already stool there. Urgency incontinence is a feeling of severe urgency, and before she can make it, there is some loss of bowel control. And the fecal seepage, see, that is also a very common problem, where after a bowel movement, the patient just cannot get clean enough. She has to keep wiping, and the stools keep coming, and they're usually soft stools. So that is also a problem, and this is many times associated with either a rectocele or a problem with constipation. So what we look at is we do something called stool diaries, and we do a couple of examinations to look for rectocele or rectal prolapse. So the stool diaries basically give us an idea as to what is the stool consistency. Our goal is to have a stool consistency of type 4, where it's a well-formed stool, that when it hits the toilet water, it doesn't break down. We don't want mushy and diarrhea-like, nor do we want pebbles. So this is the type of stool consistency that the patient reports, and we can then determine. On examination, we look for either a rectocele, which is a bulge, but here you can see that the perineum is the area between the vagina and the rectum, and you can see it's thinned out significantly. And a thin perineum would mean that the sphincter muscle around the rectum is compromised, and that could result in stool leakage. And that's often called a dovetail sign. So you can see the creases out here and out here, but there are no creases in the front. Rectocoel, as I mentioned, see if this is bulging forward, which is the rectum. So you have the bladder here, the urethra, the vagina, the uterus, and the rectum is coming, the bowel is coming down here. And the last part is the rectum. And if the rectum is bulging towards the vagina, then you may get stool entrapment right here, and that produces more gas, and then you have loss of gas. Or it can also cause, just because of the stool impaction, it can cause weakening of the sphincter and stool leakage, as we mentioned, typically that seepage leakage with constipation. Sometimes the rectal muscle becomes so weak that the lining of the rectum, as you can see, this is the line that just falls out of the rectum. And that's usually in cases of severe muscle weakness, where you have the rectal prolapse, which is coming down, and that itself can cause bowel leakage. So what we do, so this is a test called anorectal manometry. Manometry is like a blood pressure test. It's a pressure check. So in this test, we look at several things. We look at how good is the sphincter muscle, what are the volumes of the rectum filling up, was the patient able to expel a balloon that was placed in with air, and also, what was the tone of the sphincter and the reflexes of the sphincter. So that's what it does. It records the pressure of the anal sphincter at rest and when the patient is asked to squeeze, and then we look at how much the patient is able to hold, and also ultimately was she able to relax the rectal sphincter and express the balloon. Then the other test that we perform is called an anal ultrasound. So this is a 2D ultrasound and this is a 3D ultrasound. So what you look at is, this is the probe inside here, and that's the probe right here, as you can see, like a little cylinder. Then we look at the sphincter muscle. So you see this black halo around the probe, and that black halo is the inside circle or the internal sphincter, and this white halo around is the outside sphincter or the external sphincter. So we look for intactness of the sphincter during this examination. So as you can see, the internal sphincter is right here, all around. That's okay, but the external sphincter starts here, goes around, goes around, goes around, and stops here. So up here, you do not see that white halo around the internal sphincter, and that means there's a tear of the rectal sphincter, especially the external sphincter. So how do you, once we've made the diagnosis based upon the history, what the patient is complaining of, so we give them some specific forms, and you may have already filled out those forms, then we look at the examination and do these tests, then what treatment options would be the best recommendation? First and foremost, is there any underlying cause? That's very important to understand. For example, if there is constipation, it's important to take care of the constipation by education, exercise, habit training, and dietary management, or whether we take laxatives. Second is maintenance of the anal hygiene. Because of the constant leakage, there's significant irritation and soreness around the anal opening, and whether we use zinc oxide or calamine lotion would help with that. Avoiding caffeinated beverages, because that would increase the colonic motility and cause further worsening of bowel leakage. Then there are certain medications that would be indicated. For example, if a patient has a strong bowel motility and she's had a colonoscopy, which was essentially normal, and we realize that on the Bristol score, she has all mushy stools, so she is having almost like diarrhea, then we could give her a medication such as Lomotil, or mainly loperamide, which is Imodium. Lomotil has got side effects because it is a drug that could be addicting, but loperamide or Imodium could be taken in low doses and titrated up until the stools become well formed so that the patient can now control the leakage better. Pelvic floor therapy is also excellent because it is a machine that is used to improve the strength of the muscles. And what we do with this machine is that there's a little probe that sits at the opening of the vagina, another probe that sits at the opening of the rectal canal, and through that, we strengthen the pelvic muscles. So the patient realizes that she can now contract her muscles, squeeze the sphincter muscles. Because remember, even if the sphincter muscle is torn, it's only partially torn. Rarely is it completely torn. So if it's partially torn, at least the pelvic floor therapy would help improve the strength. There is no discomfort, There's no prep required. It takes about half an hour to perform this, and once a week for 4 to 6 weeks. And most patients will notice at least some improvement in their symptoms. So this could be done by itself or as an adjunct to other treatments that I'm about to discuss. If there's a sphincter break, we can do the sphincter repair procedure. Now, I usually do it if there is an associated prolapse also, and that is, it could be either end-to-end repair, which and this is repair to this, or sometimes we do an overlap surgery so as to make it even tighter and therefore get the sphincter even more contracted. It does not take too long. It's done at the opening of the vagina. Most patients are admitted overnight. There is some discomfort at the vaginal opening because of the tightening of the muscles. The risk of complications like bleeding and infection is very low. Sometimes there is discomfort is the main thing because remember, the weakness of the muscle has been happening over decades. And suddenly, in a short period of time, within minutes, I'm actually putting the muscle together. So it almost feels like as you're wearing a truss and makes it very tight. And because of that, patients have some discomfort, especially as there is swelling and inflammation, and they have to almost sit on a donut for the first few days to first week or so. The only problem is that it does not really last that long. The success rate is very low. The reported success rate is about 20% success at about 5 to 7 years out. So when you look at the sphincter repair, it is not that difficult to perform. I would do it, especially if I'm doing a posterior vaginal wall prolapse surgery. Otherwise, that's really not the first thing I would do to help with bowel control. Neuromodulation or Interstim procedure has now become the primary treatment option after we have done the dietary modifications, the medications, and also when we've considered taking care of the pelvic floor muscles by doing the stimulation and therapy. So this is approved by the FDA for bowel control problems. It's done in 2 stages. Both stages are done in the operating room. Each stage takes about 15 to 20 minutes to perform, and we wait after the first stage to see if you notice improvement. And if you have noticed improvement, then we go back in about 2 weeks to see if, and basically just put the battery in as a permanent stimulator, because in the first time when we do the stage 1, your stimulator is on the outside, so it's a temporary stimulator, and then when you go back, we just put in the permanent stimulator. So it's from the surgical standpoint, it's a very quick procedure. The risk of complications are very, very low, and the success is relatively high, where patients have noticed at least about 60 to 70% improvement in their symptoms. Again, what that means is there is at least 50% improvement in their symptoms. So as I mentioned, 70% of patients had at least a 50% improvement in the symptoms at 12 months. And most patients go home within an hour of the procedure. So risk like bleeding, infection at the site of the battery placement can happen, but it's very unlikely to happen. So this is how the battery sits, the stimulator, and the electrode goes in near the S3 nerve, and it stimulates it, and that helps improve the sphincter muscle to tighten and also the rectum to be able to hold more. So in summary, accidental bowel leakage is not an uncommon problem. In fact, it is one of the most common reasons for admission into a nursing home. And it is one of the most sad things because there is so much that can be done about this, and there is really no reason for a woman to be sitting at home in her room and be isolated from her friends just because of this problem. Do you know, even though it happens to the elderly, it could happen at any age. I've seen women who've just had their first child and they do not have any bowel control. So this could start as simple as gas leakage. So you're walking around or you're in a quiet yoga class and you're being put in a boat pose and suddenly you have gas leakage. It could start right from there and you may say, I don't want to do this class again. But instead of that, you should come for assessment. All you may need is some dietary management, pelvic floor therapy, and you may do well. Not everybody needs an Interstim. Not everybody needs the rectal surgery. However, if at all the symptoms are bad, that there is significant weakness of the sphincter, at least now we have options. When we combine the dietary modifications, the pelvic floor therapy, the anal sphincter repair, and the Interstim, there is sure enough about 70 to 75% of patients will be very happy with their improvement. Even if the cure does not happen, if there is improvement and there is satisfactory improvement, then all of us would be happy. So please remember that this is a very common condition. And as I mentioned, there are a lot of treatment options available, and including making sure that we maintain the hygiene of the local area. So all said and done, fecal incontinence or accidental bowel leakage can be managed once it's properly diagnosed. So please remember that this is a condition that could sometimes be even more embarrassing to patients than urine leakage. I've had women coming to my practice who come for bladder leakage, but when they look at my questionnaires and they fill up the questionnaires, and they are then even complaining of bowel leakage, which they realize it's more common and more bothersome, and now they can find out that something can be done about it. As female pelvic surgeons, we address the entire pelvic floor. We take care of the bladder, we take care of the vagina, and we also take care of the anal sphincter and the rectum. So not only do we take care of urinary leakage and vaginal prolapse issues, but we also take care of bowel leakage issues. So if you have either bowel leakage or gas leakage, please just don't stay there and suffer in silence. There is so much we can do to help you.